So all these insurance companies, their customer is the broker. Our patient, which is inherently their subscriber, which you would think would be their customer, is not their customer. They have to incentivize brokers, and they do it insanely. If you follow the money, they need brokers, and they need to be in their pockets. So they get the brokers to sign the employer groups up with their plan and not a competing plan.
We'd like to welcome Bill Weik, the CEO of Orthopedic Associates of Lancaster. Bill, thanks so much for taking some time out of your day to meet with us today.
Sure.
Excited to jump in and get to know you and your background and your story a little bit better. But just starting off, we talked a little bit before this and understanding kind of your path and your history. You started your healthcare journey way back in 88 or so?
I would say, yes.
Okay. And with roots primarily in revenue cycle management, similar to what we're doing here. Even had a little stint in behavioral health, but you kept getting pulled back into healthcare. So I guess the question to start with is, even when you tried to leave it, what kept pulling you back?
So I'll go through that story. I was non-traditional, joined the Navy right out of high school. And then when I came back, when I got out of the Navy, I did 4.5 years, kept taking night classes. And then I worked for Penn State University at their Hershey Medical Center, their Hershey Hospital. And healthcare was changing. I mean, that was the advent in the early 90s of HMOs, which was really bad. That's when you lost your fee for service. You started being able to bill and get paid for things. And I was not at a level that I completely understood things, but I was like, this is just tough. I mean, the patients didn't understand it. I was on the receiving end of some of the frustrations. And I was like, went back, got my degree in accounting from Penn State. And I went to a CPA firm so I could get my CPA license. And I wanted to be out of healthcare. It's like, I'm ready to exit this. I'm ready to be done. And I'm there probably a month and a half. And they said, Bill, we have a client and we have 3 experienced CPAs trying to figure out receivables for them. And can you go help them and just take a look? With all your experience, we thought you'd be a good guy to help them. So I went up there. Long story short, within a couple months, they had a big contract with the Department of Human Service, DHS in Philadelphia. And they had a lot of kids there under contract with them, and it had to do with some Medicaid billing and all this other stuff. I literally was 6 months, got a couple $1 million for them. Well, then DHS was like, we have other clients that could use your skill sets. So then I took the Colorado Boys Ranch. I did a lot of work between San Antonio and Houston, and I took alternative behavioral services out of Virginia, which they then eventually hired me. So I never got out of healthcare for like maybe 3 months. So that's what kept drawing me back.
That's amazing.
I truly feel that experience allowed me to know that I was doing much better at understanding it than I gave myself credit for.
Sure.
And I felt like I was helping people and helping organizations, and it really gave me energy. And my 5 years with FHC Health Systems in Virginia was really good.
Yeah.
Really good.
Yeah. Interesting how our paths can be different than we think, but we always kind of end up where we should be.
Correct.
Love that. Well, you've been now at OAL for 21 years. Is that accurate?
It'll be 22 years next May.
Amazing. That's huge. Congratulations. So being in this physician-owned practice setting, what's changed the most over your time there?
I think our trajectory to figure out how do we remain independent, because that's always a conversation. Probably more now recently because of all the external pressures that are going on locally and nationally. But also, how do we build something that we can recruit orthopedic surgeons that can go anywhere they want? So, we built in 2007, that was our first start of a surgery center. We built our 3 OR surgery center, and then we built our own building, which took us into the real estate realm. So we have, a real estate company, we have our surgery center, and then we have the practice. And we've continued to grow and make it very attractive for, I would say, fellows that are looking to find a place that they don't want to be in a academic center, or they don't want to be employed by a hospital. Because there are some that come out that's really what's best for them. Sure. But there are some that truly know they want to be in an independent group.
Gotcha. That makes sense. And you've created an environment that's appealing to them, like you said. Previously, right before going through the process you just described and getting to the real estate side of things and growing, like what was the landscape like 21, almost 22 years ago when you started? How hard was it to recruit physicians to come to that area?
It was very easy to manage the practice, but it was very hard to grow the practice because we rented space from the hospital. So we had restrictive covenants on growing ancillaries. And so, a young doc comes in and is trying to look forward 5 years, 10 years, and into potentially retirement. There was not a bright future in their mind. And we would have orthopedic fellows come and go, and we knew it was going to be a problem.
Yeah, makes sense. So I guess another question I have then on the private practice side. You're associated and very close to, you have an EMR, you told me, that's associated with Penn Medicine.
Correct.
So how do you maintain that balance? I guess more so, what is your opinion on the importance of maintaining a private practice or physician-owned approach with so many groups moving towards merger or acquisition with large systems?
That's a trick question. I think where things are headed, because even Penn, LGH, decided to hire their own orthopedic group, which we didn't see happening. We do all their trauma. We're the exclusive provider for their trauma service. They're a busy level 1 trauma center. They're actually the second busiest in the state of Pennsylvania, which a lot of people don't think. But it's really trying to stay with these different health systems so patients have options. And the health systems also realize that we provide services in a way different manner than their own employed surgeons do.
Sure.
They know that. I don't think they advertise it, but we still have the orthopedic division chief role at Lancaster General and not their group. So we have some key positions. Dr. Carroll's a trustee on the board, and they recognize the value that we bring to the organization being independent of them.
Sure. And create some balance, accountability, hopefully, ultimately provides better patient
quality.
care.
Absolutely.
That's what we're all looking to do. Well, let's shift a little bit into Pennsylvania specifically. We talked a little bit before about this certificate of need not being a requirement there. So how does that not being a requirement, how has that affected your ability to grow?
So on the positive side, we have 2 surgery centers.
Sure.
One's 3 ORs and one's 4 ORs. And I would say the likelihood of us being able to do it without a partner of a health system or, most health systems are the ones that end up becoming pulled into CON states so they can help, the system can help justify the fact that they have that. I would probably say definitively if Pennsylvania was a true CON state like some other states, we would not have our surgery centers that we own 100% of.
Yeah.
Because it would have been very difficult to demonstrate that the community isn't served by the hospital locally, which they were.
Interesting. Okay. So always 2 sides to that story. But your scenario specifically, you've benefited more to be able to grow more into the surgery center side and then the real estate side as a whole.
But I'll go back to the surgery center just a minute. So the thing that is not fully understood is it is way cheaper to have your surgery done at a freestanding ASC, no matter which one it is. Hospital HOPD rates are about 110% more than what we get, just because our HOPD is a hospital outpatient department. So they get, for the same exact surgery, they get a lot more money. We are not, by federal law, allowed to provide our infection rates. Our infection rates are way lower than theirs, and I think that's why we're not. That's something that they're trying to work on with Congress to be able to allow us to do that. But there's things that we're prevented from doing that the community should know, because our docs are running the surgery center and they know what they need to make it work efficiently, effectively, safely, and have better quality outcomes.
And let the consumer make an informed decision based on true data.
Correct.
Okay, makes sense. Well, talking about more on the insurance side, you've mentioned before, insurance companies have learned basically how to slow or stop your payments, including the frustrations surrounding the prior authorization process and how that's constantly in flux these days. How does that reality impact your ability to deliver care and operate sustainability?
Can I tell a story?
Yeah.
So this is something that I don't think people give a lot of thought to. And I've had a very strong conversation probably 4 years ago with one of the local Blue plans. Our patient, which is inherently their subscriber, which you would think would be their customer, is not their customer. Do you know who their customer is? The brokers. They have to incentivize brokers, and they do it insanely. If you follow the money, they need brokers, and they need to be in their pocket, so they get the brokers to sign the employer groups up with their plan and not a competing plan. So all these insurance companies, their customer is the broker. So prior authorization is a good example. All that does is it's a cover story for them to be able to say to the employer, to the broker, we have all these tools in our toolbox to make sure that the doctors aren't doing unnecessary things. But at the end of the day, the amount of money that passes down to the actual health provider, the employer that's paying for these premiums, is insane. If people would understand and follow the money on the premium, they would realize how much stays with the insurance company in the authorization process and the broker, and how little actually goes to the provider of care. Hospitals get a big chunk of it. Doctors get a small chunk of it. But there's a lot that bleeds out. But the employers are sold this that, hey, they got a great plan because they have all these tools to stop paying for things, which means denials, no authorizations. It's a soapbox for me. I could just go on. But nobody pays attention to that. Yeah. The prior authorization is a problem, and it's a tool that the insurance companies use. But I think the bigger problem is the subscriber is not the insurance company's customer. It's the broker. It's
frustrating.
Yes.
So in your opinion, what would be the best way? Again, we know there's not an active, viable solution to address what you just described. But if you could wave a magic wand, what do you think the best way would be to address holding, insurance companies accountable?
So what I've learned over the years is the insurance company knows, every insurance company has the data, and they know who the problem surgeons are. They know who's doing surgery like it's nothing. But I think their hands are tied for many reasons, mostly from a legal perspective. So then they create these policies that end up becoming applied to everybody that really is for them to fix two people. And I've had this conversation. When a new policy comes out, I call my buddy at the insurance company and say, I know exactly why you're doing this. I know who the doctor is. And you're not going to fix it because that doctor's so smart. He's going to learn this, and his dictation's going to match your rule. You're going to hurt the ones that are just trying to do the right thing for the patient.
The minority causes the issue.
Correct. So if I had a magic wand, I'd force the insurance companies to deal with the ones that are a problem and not penalize the ones that are just trying to provide good care.
Love that answer. And again, a little theoretical, but it would be great if we could create some type of a system or program that would allow accountability where it's needed
Right.
and not harming others at the same time.
Correct.
So from your perspective, what's the true cost of administrative burden on patients, providers, and the healthcare system as a whole?
The true cost? My goodness. I would say, and we're we're working through trying to understand our administrative overhead for the nuances. And if I had to guess, it's probably going to be about 25% of our actual overhead is just to deal with the insurance company nonsense. Sure. Authorizations, we have 7 people that just do authorizations.
It's crazy.
I mean, that's a lot of people.
Yeah. It's huge.
And they want paid and they want benefits and they need time off. I mean, it costs money.
And it's all created through a rule that's out of your control that you have to play by.
Correct.
And if you don't, you won't get paid.
And I would say, to follow through on that, the frustrating part is when it gets denied by Turning Point's the big one that Capital Blue Cross uses. When it gets denied, they get the letter and they call us because they think the doctor did something wrong. And again, it goes back to my conversation with them a couple of years ago. It's like they don't call you, they call us. And we're the ones that have to deal with them, and they're frustrated because they want surgery, but your people denied it.
Right.
So it's broke I think it's broken a lot of ways.
Couldn't agree more.
But they can't fix it because all the people that are employed on their end and all these doctors and all these people that would go away if they got rid of the authorization process. It's silly in my mind, and again, you can go through all those hoops and get it authorized, and then you might not get it paid.
Right. Even after all that, you could
Correct.
get an actual confirmation of prior auth, go through the procedure, and still have it denied actually for prior auth.
Correct. And it can go even one step further. I mean, you can actually get it paid, and then they take the money back because their surgery was August 3rd and July 3rd, but July 2nd, they quit their job with their employer and their benefits stop on that day, but it takes 2 weeks till they get it updated. In the interim, they paid the claim, then they get it updated, and then they take their money back. And we had no idea.
It is frustrating. I look at the system as a whole, and I think you and I know my path when I chose to move away from full-time patient care, but I think about it from a business perspective in medicine. I think if you want to practice in medicine, you go to school. It's a long path depending on obviously the specialty that you're going to practice in. But you go to years of school, you get a degree, you come out, if you're going to do private practice like we're talking about today, you have the risk of the business, right? The overhead, opening it up, advertising, marketing, getting people in the door, and then rendering the best quality care possible. And then paying someone, or like you said in your case, lots of people, money to just try to go get reimbursement for what you have done, with the care you've rendered. And after all of that risk, there's still no guarantee
That you're going to get
that
paid.
you're actually going to get paid. And I don't know any other business model out there with that type of a setup.
Yeah, the one thing as you're talking, I'm thinking about this. So the health insurance companies did get a little bit more sophisticated with their authorization process. Years ago, there was a panel with my Central Pennsylvania Healthcare Financial Management Association. We had doctors and we had insurance executives. And there was an executive from Highmark and one of the doctors from my practice. And they got into this whole authorization thing. And back then, they didn't have all these nurses and doctors doing it. They had administrative people. Yeah. And he said, do you know how frustrating the doctor goes to the Highmark exec? Do you know how frustrating it is that when your $12 an hour employee reads my note and says it's not worthy of authorizing the next step for this patient? But that's basically what it is. It needs fixed.
Sure. Well, now we're to the next step. I think I like your story, right? I mean, $12 an hour employee, not a lot of training.
What's now 23 probably,
yeah.
post-COVID.
Post-COVID, a little different. Yeah. But you have someone not well qualified trying to again, tell a physician with the training we just described whether or not he's going to get paid for rendering quality care. The other side of it is now you add in automation, technology, AI. And we're seeing payers now following this trend, right? Payers are actually using not an employee of $12 or $23 an hour, but AI to deny a claim, whether it's prior auth or not, in seconds at scale. And again, the question becomes, what tools are available for practice owners, physicians, especially in the private practice space, to combat payers that are using technology?
Well, I think it's going to be the AI component that you just talked about. I think there has to be a mechanism that for us to spend less human capital reviewing things. We talked about this earlier at the last site. We have coders that review every note of every doctor to compare it to the E&M, and that's costly. I see a time when that's going to be done by AI, and then it's just goes back to the doc. It's just going to making sure that there's the element of understanding the physician, because everyone's different. And I think it just has to be taught. I mean, that's what you understand with AI. I mean, they learn over time.
Yep.
So they're going to have to learn the physician. They're going to have to learn the documentation. But it's going to have to be done in the same way. Sure. We have to be ahead of it before it goes out the door.
Sure. Yeah, that's a good point. So maybe shifting direction slightly here. Again, you and I have talked before this and joked a little bit about you being a little bit more towards the tail end of your career. From looking back, not just at OAL, but through the entire journey, being in the Navy, et cetera, what advice would you give to other independent practices trying to stay independent in today's climate?
So I think I'm a dying breed. Now, I'll tell you a story that will help you understand that. Many years ago, and I say many, it's probably 8, 10, one of the local blues came and said, you're going to have to use this implant company to buy your implants. And they never gave thought. And this is the problem. When they make policy or they think in this tower that they live in that this is going to be best from a financial perspective, that's all they're looking at is money. They're not there's no orthopedic surgeon there telling them, I would not do that for these reasons. Well, when they came and they explained that, I'm like, you got to understand, I mean, you have to have the buy-in from the orthopedic surgeon to just change an implant because that's what they're comfortable with. That's what they get good outcomes for the patient, all those things. We went through probably 3 months and they scrapped it. Where I'm headed with this, we had another instance where they wanted us to use their visco supplement company and use their specialty pharmacy. Well, they were actually, till it came through, they were actually going to pay them more than they were paying us. And all these things were uncovered. My whole thing has been, I'm going to fight them on everything that I just don't think is right. What's happening is they come out now with policy. And even some of my younger leaders, they just read it and say, okay, effective this day. Nobody challenges them on anything. My advice would be, look at it and challenge it. They don't know it until you point it out to them that there's fallacy in this stuff. It's not right. It doesn't work. But I think they've kind of taken the David and Goliath approach. Like it's just, I'm never going to win. And I'm fighting a fight that I'm going to lose. I've never taken that position. I forged ahead. But I think that's lost, and it's empowered the insurance companies to be like nobody else is having this issue. And that's a problem.
Because people are scared to speak up.
Scared to speak up, or they don't even think that that's their ability to do it. We got another new policy. Here it is, effective in the state. This is what we got to do. So I worry that the people might, because I grew up with, managed care came and went, and I understand how that happened, and some of these things came and went. If I can't make sense of it, I'm going to challenge it. But that's not what's done so much anymore. I don't know. That's just, I think it's just these big companies are just saying this is how it is. But
it's interesting.
You might not be able to do it with United Healthcare, but your local plans you can do it with.
So fight back. Ask questions.
Ask questions. Put them to task. Meet with them.
Sure.
Meet with them. I have, just today, I've been, communicating via email with the CEO of Capital Blue Cross on some things that we're doing at WellSpan Ephrata. And I think the piece of it is you have to have a relationship with them. I don't like everything they do, but I at least have a mechanism that I can reach out to them and kind of talk through and work through things. That can never be lost. AI can't do that.
Yes.
You still need leadership to take on that role.
Right. The interpersonal connection.
Correct.
I love that. Well, again, being on the tail end of the career here and looking back and seeing all the things you've accomplished, what's been the thing that's motivated you through your career in healthcare, Bill? If you were to dial this down and say, hey, this has been my motivation, or if you want to frame it as your why, what has kept you driven in healthcare as a whole to see the positive changes and influences you've made over this long, successful career?
That's what kept me going. Just seeing the positive things happen.
Yeah.
Seeing the group grow, seeing the practice grow, seeing our ability to continue to recruit. Even just some of these stories with the insurance companies and having those wins. And I never felt like I was fighting a losing battle. I do more now, but
sure.
Over the years, that was the driver.
I love that. And so how do you take that and instill that perspective, or that, I don't know if you want to call it hope or vision, into this younger generation?
The people I mentor and the people that are interested in really understanding that it's two things. It's here and here. You can have all the textbooks in the world telling you things, but until you are willing to apply it and understand what it means to you as an individual personally, it's never going to work, because you can't follow a checklist and think that's going to make things happen. It's here and here that makes it happen. Passion and drive.
Passion and drive. I love that. So maybe as we wrap up here, if you don't mind touching a little bit more on that. So you have people you're mentoring, people that are interested in this field as a whole, and you talk to them about this, the passion and the drive. How would you define that? How would you define passion and drive for them? And then maybe, do you have any examples of people's seeing success with you?
So one person in particular, and it's not a healthcare related person that I'm mentoring, him and I have talked about this as he was looking at he's a younger guy, making a professional change. And I try to dig in, first of all, to understand what's the driver for the change. And in most cases, it's a failure to deal with the issue head on. That's a problem. It's easy to run from a problem. It's very difficult to work through a problem. And it takes the ability to articulate things. It takes the ability to be okay with them saying something that you yourself don't like. Like, you may not be aware of everything, but as you start having these conversations, all of a sudden you become more aware and you become more understanding of what exactly is what's making you want to drive away. So I really think the passion comes from uncovering things to allow you to keep moving forward. Once you learn that skill, you'd be shocked. I mean, I think you're a young guy, but you probably have a good sense of people that have the ability to articulate themselves and work through challenging issues. And then there are some that just, as soon as a roadblock goes, they just turn. That's never going to create passion or drive for themselves, because they're driving the wrong way.
Sure.
You got to drive straight into it. It may be ugly, but I want to tell you, you're going to grow from it. You're going to learn from it, and you're going to be better because of it.
Love that. It's amazing advice. Well, last question then, as we wrap up here together, Bill, is if you're given back more time in your day, right? If you had the ability to actually gain more time, how would you use it?
Outside of chickens. How would I use it? 20 years ago, I think I would have used it differently than I would today. So 20 years ago, I think I would have tried to be I was big on Capitol Hill. I knew all our local legislators, but I never really was able to finish the things that we started. Like, for example, I mean, the pre-authorization process, I was working with Representative Cutler, who's ended up becoming the Speaker of the House in Pennsylvania. I started working with him that like 15, 18 years ago. I never could really focus on it, but he did take it and it did get passed, but it's not at all helpful. I just never had enough time, to continue forward with the big stuff because there were so many big things at a time when we were growing. So if I had more time 20 years ago in my day, it would be to finish some of those big things that I at least got started and thought I passed it off, which I did, but I never got to really stay on top of seeing how it was actually going to evolve or evolved.
Love that. And what about today?
It would be spending time with my family. Like I said, it's very different, which I do.
You do. That's awesome.
Absolutely.
Yeah, we've talked about that. Well, I've enjoyed our conversation, Bill. Thanks so much for, again, being willing to chat with us today and share a little bit of your perspective, your experience, and vision on the field of healthcare as a whole. And we're grateful that you were able to join us today, and we hope we can stay in touch in the future. Here.